A very warm welcome to colleagues this afternoon. My name's Alex Heritage. I'm the Chief of Strategy and Transformation here at Hampshire and the Isle of Wight Healthcare NHS Foundation Trust. I wanted to start by thanking you for taking some time to join our first Spark session. This is a new idea that we wanted to try in the new year, really to create some space for different topics, hopefully to allow for some stimulating conversation, for sparking new ideas and bringing some of those ideas into action. We recognise how busy things are for us in health and care, and we have chosen to use this time really in terms of 45 minutes to give you some space. So thank you again for prioritising this time. The format of today's session is we're going to have a short presentation, and that will allow us an opportunity for questions at the end of the presentation. So if you could, we'd like you to wait until the end of the presentation and either to raise your hand for a question, or do use the chat function if that's accessible for you. We've done our utmost to make today's session accessible for as many people as possible, but if there's any other adjustments that we can make, please do let us know, and colleagues from the communications team will do their best to support you. So today's session is titled Shift of Care from Hospital Community. This is linked to our trust strategy with a particular focus on Aim 1, which is improving population health outcomes. And you may have seen that there is new national policy that is particularly keen to move our care into the community and to focus on prevention. But most importantly today, today's session will be about focusing on the people in our communities and our neighbourhoods, and you will hear today why this is such a very important topic for us. So I'm delighted to welcome Fraser from the NHS Strategy Unit. He's going to take us through his presentation. As I've said, at the end of the presentation, there will be an opportunity for questions. And then following today's first Spark session, we'll give you access to some feedback and also some additional reading. Hopefully you'll be stimulated and motivated to read it. So without any further ado, I will just ask Fraser to introduce himself and hand over to him.
Thank you very much, Alex, and thank you everyone. It's a total pleasure to be with you today and on your inaugural Spark session as well. Let's see if I can get things going to at least a reasonable beginning. As Alex says, I'm going to focus in on the shift from hospital to community, and the presentation I put together looks at the what, why, how and whether of the shift from hospital to community. I'm going to approach that question drawing upon work that we've done in the strategy unit. So is predominantly going to be sort of analytically focused, because the strategy unit is an NHS team that does applied analytical work. But I'm also going to take a very particular sort of policy focused lens on it, because I'm our head of policy, so that's my main interest and my main cut on this. As I said, in terms of content, I'm going to look at the what, why, how and whether. The beginning of the presentation will be largely descriptive. I'm just going to talk a little bit about what this shift from hospital to community might be, and talk a bit about the rationale for it. And then in the final section of the presentation, I'll look at whether or not it may come to pass. I'll raise my eyebrow at that, and I'll be much more analytical when I do that. When I was asked to put the presentation together, I mean, part of the brief I was given was to be sort of critical, slightly creative, slightly left field about this stuff. And so I thought, well, if the aim is to sort of spark things, I couldn't think of a better place to begin than Tigger and Eeyore. You're going to see in the presentation that both of these characters will appear. So there's going to be, I will give the final word to Tigger, don't worry. There's going to be bouncy optimism in this presentation. But I should let you know that for the bulk of the presentation, I'm going to draw the insights of Eeyore. So I'm going to use Eeyore to guide us through some of this material, offering his conclusions as we go. And then I promise you at the end, I'll give you a sort of slightly more Tiggerish ending. So here we have the first Spark session in the very capable hands of Eeyore, I'm afraid. So there we go. I'll talk for about 20 minutes or so, and then, as Alex says, we'll open out for questions. So I want to begin with a sort of sense of what this thing is, what this shift is, why it is, and how it might be intended to come about. Very, very roughly, here's one way of thinking about it. Here's a hospital, here's a community, and the policy aim to shift care from hospital to the community goes by the tag of the left shift. Now, what that means in specific terms is very much up for grabs. It's up for grabs by service level, by area, by geography, by trust, clinical, non-clinical, all of those sorts of things. So the detail of this is obviously in play. It's also worth noting, and many of you will know this way better than I ever could, we've done this in many service areas before. Learning disability is a good example. Mental health is a very good example. So in some respects, this is not new territory, and we have examples of success that we can point to. If we think about the rationale for it, the 10-year plan gives us some indication as a sort of top line rationale for wanting to shift care. Some quite extraordinary statements, really. It starts with this: if the NHS does not feel like a single coordinated patient-oriented service, that is for the simple reason that it is not one. And it goes on: it's hospital-centric, detached from communities, and it organises its care into multiple fragmented silos. And if that wasn't enough, we need to shift to provide continuous, accessible, integrated care. So some rationale for the shift emerging in the 10-year plan. Other rationales for the shift. This is a piece of work that colleagues at the Strategy Unit have done, simply looking at population age structure changes and what that will mean, how it might cash out in demand for different services. Here is the English population pyramid structure. You can see the different ages for males and females in the year 2000. And here's the projection through to 2043. And you see, we just look like a very different society, just in straight age terms. We just look different. That carries implications for the way that we would provide services. Your population, your local population pyramids are not much different, but they are different. Look at the 2043 one. It's noticeable the ratio of older people within your population relative to the English average. Again, that will change things, won't it? So part of the rationale is an aging population. With age, of course, comes increasing morbidity. The chart I'm going to show you is from Chris Whitty's report in 2023, looking at healthier aging. You're going to see morbidities over age, and you're also going to see it cut by deprivation. And what you see, of course, is as we get older as a population, an increasing range of multimorbidities within the population. And you see, particularly at the earlier ages, the middle ages, in fact, in terms of inequities, poorer people getting sicker sooner. So again, there's some notion of rationale, some changing sense of need. This next chart, this is from colleagues at the Health Foundation. They're projecting through care needs up to 2040. If you look at 2010, you can see on the chart there, around, a little under 71 years, marked by a period of no illness, then some period of time, 23 and a half years with some illness, and then a little under 10 years with major illness. You see it run through to 2019, and then you see their projection through to 2040. And what you can basically see going on within the population is that we're increasing the period of time that people are ill or seriously ill over the life course. And again, that does something for the demand for services, less obviously curative, more like the management of long-term sickness. Another rationale for the shift of care from hospitals to community, this time again from the 10-year plan, I'm going to return to this one. It's financial. The claim in the plan is that evidence is unequivocal that the shift from into the community is cheaper and more effective than defaulting to all care in hospitals. Now, I still can't quite penetrate the meaning of that sentence. It's not obviously clear, but nonetheless, there's a clear sentiment here that there's something about better use of resources if we shift from hospital to community. So another part of the rationale is financial. And you also get related rationales which are both financial and I think about overtreatment. And this is best developed, I think, in relation to end-of-life care. And here's a piece of work again from, this is colleagues at the Health Economics Unit with the Nuffield Trust, a piece of work done for Marie Curie. And you can see on the chart there, this is the distribution of healthcare expenditure. So this is just health services alone by service type. And what you see is it's very, very heavily weighted towards hospital-based care. And you get this conclusion from them that we spend about 5 times as much supporting people in the final year of life as hospital inpatients as we do supporting them with primary care, community health and hospice care. So some very clear sense in end of life, both of overtreatment and of the poor use of resources. So this is what I think you could describe the left shift as, and there are one or two sort of different cuts on the rationale for it. The way it currently cashes out in terms of sort of how to implement it, the way it's looking in policy terms is there are many different ways the intentions are likely to cash out in program terms and policy terms. I've just put a few on the slide there in front of you. I think one of the organizing principles you can point to is this notion of the neighborhood health service, and it comes in many different descriptions. So here are some of the ways it might play out. You don't have to look too carefully at that to see that there is a very obviously missing feature of all of that, which is, it looks to me to be in the political long grass for the foreseeable. So what does Eeyore make of all of this? I mean, the Eeyore-ish conclusion of all of that has got to be that we appear to be facing some pretty serious problems. Another thing that I think is interesting is many of these problems are slow burning. Many of them are driven by demography, so we can actually see some of these things coming down the line as well. So that's the sort of what, why, and how. I want to now get slightly more analytical and a little bit. There's one or two bits in this that might seem a little bit critical, perhaps. And I want to look at whether or not this shift might come about. And I'm going to do it through the lens of the Darzi review and the work that Ara Darzi did very recently when he came in and was asked by the then new government to investigate the state of the NHS as it stood. And when he did that, he looked at this shift from hospital to community. And I've drawn out one of the key quotes when he does that. He says, since at least 2006, and arguably for longer, successive governments have promised to shift care away from hospitals and into the community. He goes on, in practice, the reverse has happened. This is actually quite a spectacular story in many ways. And then he gives us this little conclusion. He says the left shift, the shift from hospital to community, could in fact be characterized as a right drift. So what I'm going to do is I'm going to examine his claim. I'm going to examine his conclusion from a few different angles. And then I'm going to suggest there's a big factor that he actually missed. So first of all, from the policy angle, I think he undereggs it, to be honest. He says 2006 as a starting point. There are documents on that screen that all talk about the shift from hospital to community going back a bit further. And in fact, one common date you hear often given as the beginning of this ambition is the middle 1970s. So one way of understanding this is that for every year I've been on the planet, this has been an aim in health policy. It's also worth noting it's not just the UK that's in this game. With the possible exception of America, most of the Western world is attempting something pretty similar. So I think Darzi's right from the policy angle, and he perhaps underplays it slightly. What about the financial angle? Are we seeing a right drift here? This is work from Sally Gainsbury, who I think is excellent at the Nuffield Trust. She just looks at where money goes. Very simple, indexed at 2016-17 and runs on. The top line is money going to NHS Trust to provide acute care, and you see it ticks up over the period. And the bottom line is money going to NHS Trust to provide community health care. And you see, even though we have an aim to shift care, we're cutting resources to community health care and increasing it for acute care. So we don't appear to be guiding resources in line with policy intention. What about the workforce angle? The character in the top left of your slide is my mum. This is Nurse Batty. She was a district nurse in Chesterfield in the 80s and early 90s. What has happened to her profession, a vital profession if we're serious about shifting care? This chart shows the number of district nurses running over time. And you might not be able to see the exact detail, but you can see the shape of this chart. Basically, what we do is halve district nursing capacity over that period, all the while saying we want to shift care. And the title of the chart, I think, is a lovely punchline: the lamentable decline of district nursing in the NHS in England. So we have not given the workforce, we've not put the right workforce in place. In fact, we've cut the workforce we would need to help achieve the policy intention. What about activities? This is a piece of work that the strategy unit has done, beginning for the new hospitals programme, actually, where we look at different kinds of activity. I'm going to show you non-elective admissions. And the thing that we're interested in is this activity mitigable, which is the universe's clumsiest term. I don't know why we've used it, but could we, of the activity we see in hospital, what could be mitigated? What do we think could be avoided through different routes? And I'm going to show you, could we have prevented it or could we have substituted it and provided something else in the community? This is from 2011 running to the start of the pandemic. The first line I'm going to show you, that's activity we don't think could be mitigated. In a sense, it's the sort of secular trend of activity going on. But look at this. This is activity that we think could have been prevented or could have been substituted. And it ticks up over that period. And I guess you can observe that runs alongside the period during which we were cutting things like district nursing, public health grant, those sorts of things. So from that angle, you can see I basically agree with Darzi on his sense that there's been a right drift. The bit where I might dissent from him slightly is his diagnosis. So how does he explain this? Well, in the review, he looks at various different factors. He first of all looks at financial flows and contractual incentives, and he says, well, look, the way we contract for acute care, the way we contract for community-based services and primary care, has tended towards money going to hospital-based services, and I think we would all agree. He looks at the way constitutional standards apply unevenly, much more to hospital-based care, and again, I think we would agree. He looks at the way data and performance measures fall, again, very largely on hospital-based care, and I think we would agree. In one of several shots against Andrew Lansley, he says that when, after the 2012 Act, we engaged in a large-scale reorganisation of commissioning structures, more money flowed through to hospital services as commissioners took their eye off the ball. Well, we will see, won't we? Because we appear to be running that test again. So in a sense, I would agree with everything he says, but I still think there's something big missing. And the thing I think is missing, I think you can see it in the following chart. This again is work we did at the Strategy Unit, this time for the Health Foundation and the launch of their Real Centre. And what I'm going to show you is changes in elective procedures, community services and general practice over a roughly sort of 15, 18-year period of time. And the first thing I'm going to show you is observed growth, so the total growth that you see in those activities. First of all, if you squint, you can see some growth in community services and consultations in general practice. And then you can zoom back out and you can see really quite significant growth in elective procedures relative to those other kinds. So again, this is part of the right drift story, but I think the interesting thing really comes when you look at what explains that growth. And I'm going to show you now what explains the total growth. Is it demography? So the population getting bigger, sicker, older, those kinds of things, or is it other factors? And if you look at community services and general practice, you see the growth that you do observe is almost entirely explained by demography. Whereas when it comes to elective procedures, there is some portion explained by demography, but overwhelmingly the growth is explained by other factors. And when you look closely at what we mean by other factors, we mean things like advances in diagnostic possibility, treatment possibilities. In a sense, what we're looking at here is the effect of innovation in dragging resources towards the specialties, in dragging it towards hospital-based care. And you can see on the chart, it is a huge factor in explaining hospital-based growth. And we've since done other work, and the same pattern follows. So basically, I share all of Darzi's diagnosis, but I just think he misses out a huge factor, which is the effect of innovation. So where does that leave us? We've had Darzi's diagnosis. We've then had the prescription in the 10-year plan. The 10-year plan, it's a long document. There's a lot in it. I've had it described to me as follows, though. There's two things really in the 10-year plan. One is neighbourhoods and the other is innovation. And as far as I can see it from my perspective, there is a tension between those two, and history suggests which way it will be resolved. And so our Eeyore, where does Eeyore get to this? Well, Eeyore can look and see that there are pretty serious problems. Eeyore then looks at the material I've just presented and says that history suggests we might be looking at an impending failure, and also that policy is overlooked a very, very big factor. I just want to move us slightly further on then and look at another factor that I think we really should pay some attention to. We've been interested in, from a policy perspective, this shift of care for a very long time. I think we've missed some serious opportunities to evaluate properly and gain insight over that time. I want to make that case by looking at a very, very common theory that I think underpins a lot of this shift from hospital to community. And the basic theory would be something like, if we provide proactive services in primary and community settings, this will prevent demand for hospital care and that it will be cheaper too. I'll just quickly look at that from a couple of different angles. This first one, if we provide proactive services. Well, one of the ways we've thought to do that recently is by using risk stratification tools in primary care, by running algorithms over data in primary care, by hopefully identifying high-risk individuals and then intervening early to prevent admissions. Well, there's a systematic review that came out, I think it was last year or the year before, which looked at what actually happened when we've done that. So what has actually played out in practice? And they conclude that the majority of real world studies either see no change or actually significant increases in healthcare utilisation. They say we really need to review these plans, the use of risk stratification, but they note that it is already widely deployed. So why have we rushed this out? Why have we already widely deployed it? And where was the sort of evaluation effort and where was the gain in insight as we were doing it? So that's one way I'd make the case. The second thing, looking at this question of whether care in communities will be cheaper. I showed you this earlier. This is from the 10-year plan, suggesting that the evidence is unequivocal that it is both cheaper and better. But if you look at work, and this is cited in some of the documents underpinning the 10-year plan, this is work from Monitor in 2015. They look very carefully at the service economics around community-based services. And they say, although schemes in the community may be cost effective in the longer run, shorter term challenges make it very, very difficult to make this stuff pay inside 5 years. And also, when we're looking at getting hold of cost savings, they tend to rely on closing hospital capacity, which, and this is sort of civil service speak, isn't it, which they think is unlikely. And given the low bed base in the UK relative to many other countries, I think they're probably understating that. So I just want to conclude just by looking at that statement. You know, if we provide proactive services in primary and community settings, it'll prevent demand and be cheaper too. I think we actually know very, very little about that proposition. And I think we know surprisingly little about it, really. So where does Eeyore get to with this then? So he thinks the problems are serious. He thinks history suggests failure, and he's worried about current policy. He's also now wringing his hands because we seem to lack the insight to make a go of it this time. And I'm afraid Eeyore's conclusion is always a depressed sigh, isn't it? But so there we go. But I kind of can't leave you in Eeyore's hands. So I just want to turn back briefly to Tigger, who can't resist a yes but in this. Tigger is going to look at current policy and see that it is full of opportunity. And he's going to point us back to the range of different initiatives going on within the current policy landscape. And if Tigger thought about it from your perspective, from the perspective of the trust, I suspect he would be pointing you towards these sorts of things. I suspect the neighbourhood agenda offers you guys some very significant opportunities. I also think, although it's not immediately obviously your bag, there's something around strategic commissioning that might open opportunities for you. And there may also be something around the idea of the integrated health organisation that offers you things too. There's some further reading and so on which I can send round and give you when we pop the slides around. But Alex, I thought it was probably quite enough presentation from me. And I don't know if people have come to us with questions.
Excellent. Well, Fraser, thank you. We gave you a brief. We didn't necessarily give you the brief to include characters such as Eeyore and Tigger, but I think it made the point really nicely. And no surprise, I'm glad that you did end with a little bit of Tiggerish enthusiasm for us. I do think it's important for colleagues that have joined us this afternoon that this is to be thought-provoking. We certainly don't want to feel like we're demonising any part of health and care or blaming anybody in the situation. What Fraser's done, I think, really articulately for us there is just show us some of the policy, some of the evidence and some of the thought process. So the latter part of this Spark session is really for colleagues on the call just to ask some questions. It might be that we've got some answers, it might not be. Just mindful that Fraser is coming external to Hampshire and the Isle of Wight, the southeast region, so we might not be completely up to date with our specific situation, but he's such a valuable resource. It's a short period of time for us to gain a little bit more of his insight. and then I will wrap us up so that we can finish at 1:45. So I'm really grateful. As I see it on my screen, I think, Michael, you've got your hand up. So if you're able, do you want to ask Fraser a question?
Yeah, there's two parts I'd like to concentrate on. First of all, let me just emphasize I'm voluntary elected governor for Sussex Community Foundation Trust. So none of what I'm going to be talking about has medical background. Please bear with me. What I would particularly like to focus on is the impact that moving care from hospital settings into the community has an impact on the community. And I feel it's very much part of what is missing from this discussion. You know, there's a large sort of element which in the voluntary sector we call VCSE, voluntary community social engagement, SE, which seeks to engage with the NHS and try and bring together skills and resources which are external to the NHS but have a voluntary support mechanism which is there. They're a group of people which have got used to doing a lot with very little. So I think there's a really big discussion that needs to take part in that. And, you know, I will leave that open. The other part I wanted to talk about was something which I feel is very much missing from a lot of the discussion around health and healthcare in the NHS, and that is mental health. Because it's very good talking about what can be done to physically support people, but there's a large number of people which have day-to-day problems of not just surviving the real world, but actually trying to balance the way that they live within the world, most of which doesn't want to talk about or have anything to do with mental health. It's all very well talking about nice shiny websites that go, "Oh, you okay," etc. But there's also a very large community in hospitals which will never have the opportunity to address their illnesses in the community, medicine, management, things like that. I'm going to leave it at that because I'm starting to waffle a bit.
You'll never waffle quite as much as me, Michael, I'm sure. Thank you for your questions as well. I mean, I'm just going to echo very much of what you've said and then just put a particular gloss on it, given my personal experience and knowledge in this sector. Then the chart I showed you, which was from the Health Foundation looking at health needs projected to 2040, which basically showed that we are due to just increase the stock of illness in the population. If you look at what underlies that, a huge portion of it is mental health, an absolutely huge portion of it. So I think the problem you're pointing to, I would recognise already, and it seems to me is set to grow, and so it'll be increasing demands in that area. The point you make about the voluntary sector, I mean, I can't help now but see this through a very personal lens, which is that my wife runs a voluntary sector organisation which runs mental health support. And they are at the moment losing contracts from the NHS and finding the ability to engage with the commissioning side of the NHS just bewildering. I mean, absolutely baffling. For reasons that all of us will know if we understand and we know the commissioning part, because it is unfortunately having to rip itself apart. The thing that maybe gives her some hope and that would leave me with a little bit of hope is this notion of neighbourhood-based care, though, because that is something that I think the voluntary sector is excellent at, is knowing its communities, knowing the detail of local areas, knowing people's lives in much more detail than statutory services typically do. So there's a bit of me that whilst you can see I'm torn between the Eeyore and the Tigger on this, but I can see a reason for being slightly Tiggerish about that too.
Lovely. Thank you, Michael. It's always important to get the first question opened up as well. It gives confidence to other colleagues to ask. So I'm keeping a little eye on the time, and it'd be great if Chrissy, if you're able to ask your question next.
Yeah, okay. It's not actually a question as such. It was more, this is probably one of the most refreshing presentations that I've been to talking about this. And I've worked in health for 26 plus years. I now work for a hospice. So I was really interested in your slide around the cost of end of life care, and the shift has to happen. And I've seen money move around the system. I was an ex-NHS commissioner. And I've seen money move around the systems, and I've seen the shift from when we moved learning disabilities into more community-based care. A couple of things for me. I mean, it can work. It needs people with balls to make it work. We need public health messages, and we need social care. And without the social care and the public health messages, when I'm talking about public health messages strand everything that all of us do. So for me, a public health message is around people having the confidence to talk about dying, because we are all going to die, and making plans around what's important to them for dying. And listen, the gentleman before talking about the voluntary sector, and it heartens me that your wife works in that industry as well, because for every pound of statutory funding that we have, we put about £3 or £4 in, and hospices, like others, have some very innovative ideas around how we can keep people safely at home, relatively inexpensively. And at our hospice, we've got two, one in Hampshire and one on the Isle of Wight. We've demonstrated with some very simple measures. It was a band 6 OT, preventing hospital admissions. When we ran out of charitable funding, I won't name and shame, but the system were unable to support us with that, although we could evidence. Look, the percentage of people that are dying, it's about 1.5% of the patient population die every year. Everybody feels very strongly about their own areas. If you get it right in end of life, you can use those examples to make it right. So around transport, around hospital, preventing hospital admissions, around drugs. I mean, there's so many elements that I'd really welcome a conversation with somebody that's prepared to listen and act. So well done, a really good presentation. Thank you.
I mean, honestly, Chrissy, that is just charming of you. Thank you. That's very kind of you to say. I've posted a few things in the chat, basically because it looks like our interests. The Venn diagram is absolutely smack over. I'm completely obsessed with the sense that end-of-life care, but again, both from a personal and professional perspective, if we get this shift right, that's where you have to see it. If things like strategic commissioning mean anything, they mean improving end-of-life care. If neighbourhood-based care means anything, it means improving the deaths that people have in this country. So I've put a few articles and blogs and all the rest of it that I've put in that basically just reflect everything you've just said back to you. You will also see at the beginning of one of them some hints at my atrocious parenting. So you get to you get a bit of that in there as well.
Thank you, Fraser. I am mindful, I've just seen a note in the chat that we probably are going to run out of time, and I don't want people to be disappointed. So I'm going to try and persuade Fraser after today. Fraser and I will try and get through any questions in the chat that haven't been answered today. Again, I may have explained it earlier on. We wanted to limit it to about 45 minutes just to respect people's time. It may be that people don't get such a thing as a lunch break, but we wanted just to respect how busy people are. So we just wanted to put a short 45-minute session in. We are going to ask for your feedback, and the feedback might be that we've got to create a little bit more space for questions. So I am sorry if you have got a burning question, but if you have got access to the chat function, and we'll provide our email address. If not, we will do our best to answer all questions. So I'm sorry that we've probably got room for maybe one or two. So Kay, you've been really patient. Can we go to you next, if that's okay?
Thank you. sorry, I'm from the dark side because I work at an acute tertiary trust. But one of the things that struck me, and I would really be interested in your thoughts on this, is that quite a lot of the issues we have in the hospital is with where we end up overspending because of patients' choice. And I'm just wondering how much, if we can encourage people in the community to actually want to get their service in the community and get that voice much stronger, it may drive the money into the community for that reason. Because we talk about patient choice within the tertiary acute section in the hospitals, and it is an issue. So if we if people don't want to go into hospital, which they often don't, if we can get that voice across more, surely that would help with moving money into the community. I might be being naive, so I do apologise for that.
I would say neither naive nor from the dark side. Okay, I wouldn't accept that for a minute. The other thing I'm conscious, I don't know very much about the role that patient choice plays within this. I really don't. I recognise everything that you say, though, in that individuals and families will have to recognise that the community-based alternatives are preferable to them, when we often simply default to thinking that hospital is the safest place. Again, that's perhaps why I think end of life might be an obvious place to begin with many of these things. I guess the main factor that I pointed to in the presentation that I think probably does relate to the institution you work in is that it's medical advance that drives a lot of resource allocation, and I think that's an underappreciated factor in it. One of the reasons why I think that is particularly interesting is because we want medical advance, don't we? So we, the population, we, the public, we, the taxpayer, we want medical advances. So we simultaneously want things that are self-defeating in some cases. So I think there are very, very big and difficult trade-offs for us all to make, actually.
Brilliant. Thanks, Fraser. Can we go to Rosie next, please?
Yeah, hi Alex. Just say I have popped my message in my question in the chat as well. So if it's easier in terms of time, I'm happy to get that answer later, if that's preferable.
No, it's keen if you're able to summarise it. I can see your question in there, but it'd be good just to get as many voices heard.
Sure, thank you. So I was saying it's a bit of a niche question because I work in the Recovery College. Really interesting to hear from people from different areas as well and the different perspectives on this. Recently, we've had the Recollect study come out that's shown that engagement in recovery colleges reduces hospital admissions and provides a number of benefits, including reducing costs as well. So I think for every £1 spent, it equates to a saving of over £8 when it's invested in the recovery colleges. I was just curious if there's anything within the policies that looks at the recovery college input in that sort of shift to the left, and whether that would be part of those neighbourhood centres and neighbourhood services that Fraser was talking about. But again, appreciate it's a little bit niche, but I'd be really interested to know if we've got a part in that plan, really.
It's probably a little specific for me to say very much. The thing I would say is that it's just because it's a nice recent example from my working life that springs instantly to mind. We've been asked to do some modelling work to look at neighbourhood care, and the question, of course, is to what extent do you think it could reduce demand on unplanned use of hospital services? So, of course, the first thing we went to do is to crack out the literature on that question. And given that we've been in this game in policy terms for about 5 decades, it is startling how little we know. We've just not done the work that I think you're describing having done, which is to do proper evaluation work and to learn from it and to accumulate insights. And my sense is that we should do that because we will still be in this game in another 10 years' time, another 20 years' time. We're not going to crack this. So we should be as interested in the accumulation of knowledge as we are in activity.
And probably with a Hampshire and Isle of Wight healthcare hat on, Rosie, what we are absolutely committed to around the neighbourhood model is to perhaps to start with is to offer what we might describe as sort of what is the core offer for neighbourhoods in terms of health and care, but really importantly, what is wanted and needed within those distinctive communities or neighbourhoods, and that's going to look different, and it needs to be different in different parts. I genuinely am Tiggerish about the neighbourhood and the community agenda. And I think sometimes because we haven't, within mental health and disability, neurodiverse services, had some of the evaluation, as Fraser's shown, we've not been able to prove the case so strongly. So actually, the study that you suggest needs to be understood more. I would argue, and I think Fraser showed the journey of acute adult mental health predominantly, I think the chart was, that we have been doing this successfully for a number of decades, and it's sort of overlooked. So again, today, we don't want to fall into the trap just to talk about community physical health. We're talking about all of our community, and I think leading off with the question before in terms of physical and mental health, nobody really in our population makes a distinction. Statutory services, we suddenly have different conversations. That's not what our population wants. So part of these sessions, Rosie, is for people to showcase some things. So it might be that with your permission, we might want to send that study round and about to people that have attended today. So it might just raise more awareness. If you're not involved in the neighbourhood programmes, we'll connect you so that you can be linked in there. We're at 1340. We're at 13:42, so I just want to give an opportunity. Charlotte, you've waited really patiently. We'll hear from Charlotte if that's okay, and then I'm just going to wrap us up.
Yeah, I think my hand came down at one point. I think I was higher up the queue at some point, but that's okay. That's all right. These things happen. So I guess I'm really, it was again really want to say it was a great presentation, and I really appreciate the fact that what you didn't do is just put a really positive spin on it all and say everything's going to work out really well, because I think I would have just cried at that point, because I think we all know that's not the case, and we've got to put an awful lot of work and effort into making this a success. So I really appreciate the tone of your presentation actually. But my question is around the impact of community therapy and that shift of therapy services from acute out into community, and the evidence that there is potentially, or are we starting to understand the evidence of the benefit of that, particularly around getting into that prevention world of self-management of these long-term conditions we're seeing more of, and also that sort of move to early intervention rather than, unfortunately, where we seem to be sitting all the time is in that crisis management, mission avoidance perspective. So that's my sort of general, where does community therapy sit in with this?
I'm super mindful of time. I'll be very quick, and also that's not a topic I know brilliantly well, so I won't bumble ignorantly into your into your area. The two things I think I'd point to, well, two things I think I'd say in response. One is that the strategy unit, we're trying to do work to get an analytical grip on what can be done to prevent activity turning up in hospitals. So we've done an enormously detailed piece of work to find 90 categories of activity, of things that we think can be prevented and provided more in the community. And so we can see some areas where it's possible to do it, and there may well be some overlaps with what you're describing there. And then the second, which just touches actually on two or three of the different questions that we've had before, is working with people. The shared decision making is one of the best evidence things that you can possibly, I mean, it's where you'd spend your last tenner probably. Really making that a reality would also shift the dial.
Excellent. Thank you so much for colleagues who have attended today, who have listened. There will be the opportunity to listen back, so we're going to do our best to send the recording around, as well as the presentation that will work for colleagues. Those of you that have kindly put questions in the chat, Fraser and I will do our best to provide some answers back. We didn't know how the Spark session would work because we've never done it before, and we want to be a learning organisation. So we will provide you with a feedback form. Please be honest around your feedback so that we can improve it. And we've not gone as far to suggest that we might run more of these because we didn't know how you would receive it. So your feedback genuinely will be important to see whether or not we run some future Spark sessions. If you would like any more information on this topic, Fraser's posted some links, but there will be some further links that we will share with you. And if it is indeed that you would like to focus on something else in a future Spark session, also let me know, because we would like to showcase the wonderful work that's actually happening here in our system, our organisation. So it's not all going to be external speakers. I would love for us to have a Spark session internally. We're at 1:45. Thank you again to Fraser for his preparation and his presentation today. And I do look forward to your feedback and hopefully a future Spark session. Bye for now.
Thank you.